So at ASH 2025, we also had a chance to present an abstract on distinct trajectories and prognosis of measurable residual disease in translocation 11-14 multiple myeloma. The reason to look into this information is because we saw recently on the MIDAS trial, the patients with 11-14 translocation were less likely to achieve MRD negativity post-induction therapy than other patients, including patients with cytogenetic high risk, generating the concern that perhaps in the era of quadruplet therapy and autologous transplant, these patients might actually have a worse prognosis. We long recognized that 11-14 has different biology altogether. The cells look different morphologically, they have different immunophenotypes, and their pattern of response to therapy can be somewhat distinct, as exemplified very well in the example of the BCL2 inhibitors. So we took advantage of a large data set of 310 patients, all treated with quadruple therapy, all treated with autologous transplant, and all treated with post-transplant MRD-adapted consolidation and maintenance treatment to better describe the trajectory of MRD negativity in 11-14 versus other patients. And what we saw was indeed the rate of MRD negativity at 10 to minus 5 and 10 to minus 6 was lower in 11-14 before transplant, remained lower but with a substantial increment after transplant. And if you look at MRD negativity achieved at any time, it's still somewhat lower in the 11-14 patients than on 11-14 negative patients. The same applied to 10 to minus 6. Also, the timing to achieve MRD negativity was slower, was 7.7 months in MRD in 11-14 negative patients, and was over 13 months in 11-14 positive patients. However, we found that overall, the rate of sustained MRD negativity, so 2 consecutive measurements at least a year apart, was very similar between 11-14 positive and negative patients. And overall, the prognosis of 11-14 positive patients was superior to their 11-14 negative counterparts. So in the era of quad and autologous transplant, despite the slow achievement of MRD negativity, patients with 11-14 actually have a better prognosis than their counterpart. And that begs the question if MRD negativity matters at all. So we did a multivariate analysis, including cytogenetic risk, actually ISS, achievement of sustained MRD negativity, and 11-14 status. And we showed that 11-14 status remains and achievement of sustained MRD negativity are both protectors of PFS events. So in other words, the best case scenario is when you have an 11-14 and achieve MRD negativity. And none of those patients had progression despite the coming off therapy due to their sustainability of their MRD response. So we think there's the disease that is just somewhat different, does not have worse prognosis, might have better. And we start to shape a profile of patients with this abnormality that actually are great candidates for treatment discontinuation because they seem to have ridiculously low rate of progression despite no further therapy.